probably repeat some of what you've already learned, but we're going to take that and we're going to move into lungs and heart and look at cardiovascular development, lung development, in particular, and apply those to some congenital anomalies as well. So, who can tell me what that is? Is it a fetus or an embryo? It's an embryo. What's the difference? Fetus is anything after the end of the 8th week. So at the end of the 8th week, it's a fetus. Before that, it's an embryo. An embryo, all the primordia of the organ systems, all the primordia of all the structures you see in the adult are laid down. During fetal stages, those primordia then go through histogenesis, go through further development, and become the organs or the structures they're going to become. So here we're looking at about a 4-week, closer to a 5-week embryo. You can see head structure, pharyngeal arches are starting to develop, limb buds are starting to develop. You see somites coming out here. You can date this embryo off the presence of both limb buds and their structure. You can also go through and count somites and date this embryo off the somite. What we're going to talk about today will encompass a lot of this pharyngeal arch structure, as well as this big bulge right here. This is the heart development. Heart develops very early, and heart has to function while it's developing. So it begins to beat at about 21 days after fertilization, where you get cardiomyocytes beginning to contract. It's not really beating. But shortly after that, the heart tube can start moving blood in one direction through the embryo. And this is important because at this stage, this embryo is getting too large to gather oxygen and nutrients just by straight diffusion. It needs an active method in order to distribute things through the body. This embryo is also hypoxic. The embryos and fetuses are in a natural and constant hypoxic state, and that hypoxia helps vascular to develop, helps the brain to develop, helps the lung to develop. There's all sorts of different things that are going on at the same time. So a lot of the material you'll see today is from these texts. This Langland's Medical Embryology is a good basic overview of embryology. Larson and Carlson take it a little bit further. Carlson taking it a little bit more into molecular and to other pathways. There's also a great website, this University of New South Wales. This guy's been building this site for about 20 years. Anything you want to know about embryology is at this site. It has animations and it has all sorts of things, so I recommend going through that. You also, on your, what do you guys use now for, it's not Blackboard.
Canvas.
Canvas. On Canvas, you should have a PDF that was posted. All test questions will come off that PDF. So really what I would say today is sit back, relax, and just kind of soak this in. Well, a lot of this is here, and we're going to talk about it in order for you to get a better idea of anatomy. So get a better idea of relationships in anatomy and how things form and what their functions are. So today we're going to look at heart and lung. Have you guys done dissections yet? Have you done the anatomy yet? You don't know heart anatomy yet? Okay, so this is rather difficult then. We have to go through the heart, we have to go through the lungs with you not knowing the anatomy, so that's different. So the lungs, there's 3 chambers in the thoracic cavity, there's 2 pleural cavities, and a pericardiac cavity. All 3 of these cavities, plus this peritoneal cavity that's housing all the abdominal contents, were all derived from the same embryonic cavity. An embryonic coelom is what it's called. And then it goes through a septation and is subdivided into these 4 chambers. The subdivision is very important because these lungs, at the time of birth, the lungs are developing all through embryonic and fetal stages, but they're non-functional. They're unnecessary. They become functional at the time of birth, and these lungs have to inflate and function instantly at the time of birth. Otherwise, the newborn's in distress and needs to be attended to. Same thing with the pericardiac cavity. It has to be there and functional, providing lubrication for the heart to move properly. But this has to start much earlier, around the 3rd or 4th week, so the heart can develop and function at the same time. So heart development is very complicated, but the heart has to be able to move blood while it's even developing. So it's a fascinating way to develop, or it's a fascinating structure in how to develop it, and also with the outcome of that development. So if we look at also in these pleural cavities are lined by a serous membrane, a mesothelium. It's called the pleura. And that pleura is important because it seals that cavity off. It creates a solid closed system that when the diaphragm contracts, the diaphragm right now is this big dome structure. When it contracts, it kind of flattens out. And when it flattens out, it increases the size of that pleural cavity, and the lung increases with it. The lung is a passive organ. As that pleural cavity increases, the lung gets larger, air comes in through the trachea, through the bronchi into the lung. When the diaphragm contracts, that cavity gets smaller, it pushes the air back out. So the lung is a very passive structure, whereas the heart is a very active structure. It has to move material at all times. So if Dr. Latimer went through, hopefully went through endoderm, mesoderm, and ectoderm. So shortly after this embryo has gone through gastrulation, so now you have an endodermal layer in the blue here, and a mesodermal layer in the red, and an endodermal layer in the yellow. This ectodermal layer here in the blue is going to go on to form all the skin of the embryo plus the central nervous system. So neural tube folds up, detaches from the overlying ectoderm, and now you have a central nervous system that's formed. Right at the junction of this more lateral blue, that's going to become the skin. Right at the junction right here, neural crest cells will start to delaminate from that ectoderm and migrate through the body. And those neural crest cells are going to go on to form peripheral nervous system. Plus, they're also going to form adrenal medulla, all the melanocytes in your skin, many other things. But this is a very important stage. If anything goes wrong with this stage, in a lot of cases, it's a lethal situation. It's a lethal anomaly because this is so early. The mesoderm here in the red will go on to form notochord. In the adult, the only remnant of notochord is in the intervertebral disc in the vertebral column. This paraaxial mesoderm, so this is axial right in the midline. Paraaxial is the mesoderm alongside the midline. This will form somites. Those somites will go on to produce all the skeletal muscle in the body. Just lateral to that is intermediate mesoderm. That intermediate mesoderm will go on to form gonadal structure, kidney structure. Just lateral to that is lateral plate mesoderm. Some of the lateral plate mesoderm will split into two regions. There's a somitic mesoderm that will combine with the overlying ectoderm, and that will become body wall. There's the splanchnic mesoderm here will associate with the underlying endoderm, and that'll become the primitive gut tube. So all of these structures during gastrulation is laid down as a three-layered stage, but then you go through this embryonic folding that will move this from a more disc-like embryo to a three-dimensional embryo that we saw in that first slide. So embryonic folding has occurred. The embryo is three-dimensional now. It's not a disc. This is a cross-section, probably about mid-thorax, a little bit higher. You see lung buds starting to form. This cavity right here is going to become the pleural cavity. You also see primitive heart tube starting to form. This cavity is going to become pericardiac cavity. And look how big the heart is relative to the spinal cord and the lungs. The heart develops, it's very, very large very quickly, and then the embryo starts to grow around and it becomes relatively small compared to the rest of the embryo. These two shelves, these are called pleural pericardial folds. They'll grow out and they'll meet at the midline and they'll separate those pleural cavities from the pericardiac cavity. So embryogenesis is continuing. Lung buds are still starting to form and grow. You can see these lung buds really stretching out, looking like a normal lung. They come to push through and surround this pericardiac cavity. And you can see how much smaller the heart is from this embryo to this embryo relative to the growth of the embryo here. So we're still looking at embryonic structure, but we're looking at a late embryo where the heart is much, much smaller. If we looked a little bit more, took a little section more toward the feet, we'd be into liver, and the liver would be huge compared to everything else. So all these stages that the embryo is going through are important for anatomical development, but you get relative size changes in structures in the embryo as it grows, as it progresses. Diaphragm, as heart develops, diaphragm is also developing. So this cross section through the embryo, you can see these two little lung buds here, heart's developing, diaphragm just a little bit more caudal. It's starting to develop. This develops initially as a mass of tissue called septum transversum. And then it continues to elaborate and eventually seal off what would be peritoneal cavity from the overlying thoracic cavity. Finally, muscle cells will start to migrate in from the body wall, and those will produce the muscle cells of the diaphragm, whereas the septum transversum will remain as the central tendon of the diaphragm. If you haven't seen all this in anatomy, I'm sure it's kind of difficult to understand, but you'll recognize these terms when you get there. So here's a mature diaphragm. We're looking at it from below. Here's the central tendon of the diaphragm. This is all the musculature of the diaphragm here. All that musculature migrated in from the body wall, joined with that central tendon to produce this functional diaphragm. This folding, this bringing, this, if we back up just a second, this embryonic folding that brings all these structures, this is called lateral folding. So we're looking at an embryo cut transversely. This is the sides of the embryo, left and right side. They're going to come in toward the midline, kind of pinch off, and eventually fuse at the ventral midline in about 4 weeks. And that's the end of what's termed lateral folding. As this happens, it's closing the chest, it's closing the thoracic cavity, it's closing the abdominal cavity, except for the umbilicus is still sticking out. Things can go wrong. Things can happen. One of the things that can happen, it cannot close properly. If it doesn't close properly or to the degree it's supposed to, you could have gaps in the sternal structure of the thoracic wall. You could have costal abnormalities, abnormalities in the ribs, abnormalities in the clavicles. Sometimes it doesn't close at all. And the embryo, everything in the abdominal or the thoracic cavity stays exposed to the amniotic fluid. Amniotic fluid is really fetal urine. It's added to by the fetus throughout development, and the amniotic cavity gets bigger and bigger because it's adding more and more fluid to this cavity. That fluid, with time, the fetal urine becomes more and more caustic with time. And that amniotic fluid can start to degrade this tissue that's exposed to it. It doesn't degrade the embryo itself because the embryo itself develops skin very quickly to protect itself from the amniotic fluid. But the internal organs do not have that skin, so they'll degrade with contact with the amniotic fluid. So if this doesn't close properly and these organs are exposed to amniotic fluid, by the time gestation is complete, liver, colon, structures like that may have degraded so much that they're unusable, that the embryo is not going to, or the fetus is not going to survive. This can be gut loops that hang outside, or it could actually be heart and lung that are hanging outside of the body if closure doesn't happen properly. This is called ectopic cordis, where the heart's kind of sitting outside of the embryo. There's also problems that can arise in formation of the diaphragm. If the diaphragm, the septum transversum, doesn't migrate properly, or the muscle cells don't migrate in from the body wall properly, you can develop what are called diaphragmatic hernias, holes that develop in the diaphragm. The most common is the lower left quadrant here, these Botulek hernias. You can get a herniation of gut tube into the pleural cavity. Now, it probably doesn't really damage the gut tube that much, but it can interfere with the formation of the left lung in this case. In this case, the left lung is now in a very constrained compartment. It's in relation to tissue that it's not supposed to be in relation to, so that left lung can be damaged quite readily. Now, right lung this child can still survive because right lung is normal. Once the child's born, you can pull all this gut tube back into the gut, seal off that diaphragm. The diaphragm becomes functional, but you may be at a loss for the full lobar structure of the lung. So this is the most common, but you can get hernias at any location around the diaphragm. Herniations, depending on where it is, you can have herniations in the pericardiac cavity that can impede or damage the heart development as well. So 1 in 3,500, 1 in 5,000 is the incidence rate for a diaphragmatic hernia. Is it rare or common? rare. How many children were born at UH last year? Say about 1,000. So it would take 3.5 to 5 years to see one of these cases. So 1 to 2,000 is considered the cutoff between common and rare. You see more of these at UH because UH serves a large metropolitan area, so you have a lot of people who are born at other hospitals who come to UH for treatment. So you can see quite a few of these at UH throughout the year, but not all of those children were born. So consider 1 to 2,000 to be the cutoff between common and rare. Okay, we're going to start with lung development. Lungs there's two lungs. They're separated in their own individual pleural cavities. Those pleural cavities do not connect with each other in an adult. The lungs, the airway of the lungs includes the trachea, the primary bronchi. Those are the first branches from the trachea. Secondary bronchi here. They're also called lobar bronchi because these are branches going directly to lobes. The left lung has two lobes, a superior and an inferior. The right lung has a superior, an inferior, and a middle lobe. The left lung also has this thing right here called the linula. That linula is a remnant from what would have been the middle lobe on this side. So the lungs try to look the same, but you have a heart that's impeding on it. You have other things that are acting on this left lung that make it fuse that middle lobe to the superior lobe. So trachea, primary bronchi, secondary bronchi. Then you get into segmental bronchi. The lungs are divided into segments. The lungs are divided into lobes. Each lobe is divided into segments. Segments are very important. Segments demarcate a region of the lung that's disconnected from other regions of the lung by the airway and by the pulmonary arteries. So if I had cancer in this apical segment of the lung, I could go in, resect that segment out and not affect any of the other segments of the lung. So it's a surgical landmarks that you can go in and you can pull out different regions of the lung and still maintain an intact and functional lung. Lungs start out, this is primitive gut tube. Remember, that's derived from endoderm. This primitive gut tube is surrounded by that splanchnic mesoderm, so all the smooth muscle, all the muscular coat of the gut tube is derived from splanchnic mesoderm that's surrounding it. Up at cervical levels, there's a little diverticulum, a little outcropping that comes from that gut tube. It's called the respiratory diverticulum. And this separates from the gut tube in an unusual way. It's not just a little bleb or branch point that comes out. It actually separates longitudinally. These two shelves develop in a longitudinal segment under signaling from the endoderm itself. And then that whole thing pinches off as this respiratory diverticulum. Very quickly after it does that, this diverticulum branches into the lung buds. So this would be the trachea, and this would be the primary bronchi. Very quickly, those lung buds will then go on to continue branching and continue branching. They'll branch about 23 rounds of branching, which is a lot of branching. So by the time it's done, you have about 300 million different terminal branch points of this trachea. So you're trying to create as much surface area that the air can get to in this lung as fast as you can, so by the time the child is born, they have enough surface area to exchange enough oxygen so the child can survive. Most of these alveoli, most of these 300 million alveoli, the alveoli are the functional units of the lung, most of those develop after birth. So the child is born with a minimal amount of alveoli to keep the child alive, then more and more are added on. So you can imagine if a child is born premature, the alveoli are much more reduced. The child could be in distress just from being born early. There's other factors that are required. Surfactant production by these alveoli are required in order for when the child takes its first breath, these alveoli can open up. They can reduce the surface tension so you can get these two membranes to separate from each other. If the child isn't making enough surfactant, that's even more distress this child is in. So the earliest viable fetal stages are around 22 to 23 weeks. That's when enough surfactant is there and enough alveoli are there. So if the child is born that early, they will survive. But you can see the branching in the lung buds here. Here's the segmental or secondary bronchi that are starting to develop. Now you're into tertiary bronchi. These are going into segments. Then it'll keep branching another 20 rounds. all this time, the rest of the gut tube is developing. So you're looking at 28 days to 38 days, 10 days you're already into tertiary bronchi. So this is moving along very fast. So 38 days, you're looking at 5 weeks, a little over 5 weeks. You still have another 3 weeks of embryonic development to proceed. These lung buds are branching into the pleural cavities. The pleural cavities, think of the pleural cavities as balloons of pleura. This branching is pushing into those balloons. So it's like a fist in a balloon. So as this lung bud here, or as this tertiary bronchi or lobar bronchi here pushes in, it's covered with that pleura. And that's separating, that's now regionalizing this pleura between pleura that's on the wall of the pleural cavity, this is called parietal pleura, or pleura that's sitting on the surface of the lung itself, it's called visceral pleura. Viscera is an organ. So this fist in the balloon concept is true for lungs, it's true for gut tube, as the intestines start to develop, it's true for liver, pancreas, all those structures. Fetal breathing movements begin at about 12 weeks of gestation, so early fetal stages. These breathing movements are really just gulping. They're just gulping amniotic fluid. And you're trying to drive amniotic fluid into the gut tube because it's important for amniotic fluid to move through the lung and move through these airways because it's important for development. If you go and you can do experiments, not on humans, but in other animal models, you can do experiments where you can close off that or inhibit amniotic fluid from going into the airways, and the lungs, the development of the lungs is greatly reduced. So there's either something in the amniotic fluid, it may be just the volume itself that's helping for the lungs to develop, but if you inhibit these gulping movements or these breathing movements, lung development is greatly perturbed. Also, this gulping movements is important because the embryo, at about 8 weeks, the most proximal portion of the gut tube opens to the amniotic cavity. I'm sorry, about 4 weeks it opens up, but at the other end, at the anal end, it opens up at about 8 weeks. So the gut tube at 12 weeks is completely open to the amniotic cavity on either end. And so this gulping movement is driving amniotic fluid in, pushing it out the other end, and at the same time, the kidneys of the fetus are already working. So the kidneys are adding more and more fluid to this amniotic fluid. If there's damage to the gut tube, if there's damage to the kidneys, if they can't produce this, you can get a reduction in the amount of amniotic fluid. Now the embryo is growing up in a very small cavity, amniotic cavity. This is called oligohydramnios. And it can damage facial development, it can damage limb development, it can damage gut development. So all these things have to happen at the same time in the proper manner for development to proceed properly. And it's really, to me, it's really amazing anybody comes out normal. Breathing movements can be reduced by smoking or by alcohol ingestion. So these gulping movements that are important for lung development that start at about 12 weeks, drinking can reduce that activity. And at about 12 weeks, a woman may not even know they're pregnant at that time. So this becomes a difficult situation in terms of awareness of pregnancy.
Is there a different effect? Because we talked about how within the first 4 weeks is when there's like the most development. So like the harm of alcohol or smoking or other sorts of harmful consumptions, it can like affect most during those first 4 weeks. Then you're saying 12 weeks for the fetal breathing movement. So is that moving within the first 12 weeks or moving forward?
Well, the first 4 weeks are very critical. They're very susceptible to damage. So teratogens, alcohol, things like that, the embryo is very susceptible. By the time you get to 12 weeks, now the smoking or the drinking are affecting specific symptoms rather than the embryo as a whole. Drinking and smoking before 8 weeks can affect placental development greatly. So you have all sorts of different systems that are affected globally at an earlier stage. A 4-week embryo is affected smoking, drinking, just pollution in the air, maternal nutrition, all sorts of different things that affect this. Is a very susceptible period. And that really doesn't change till after embryogenesis, till you get up to fetal stages, to where You know, at a mid-fetal stage, you know, I've heard many times where you tell a pregnant woman have a glass of wine at night, it's not gonna hurt you. Well, that's really kind of true. It's not gonna hurt the fetus anymore, because all that susceptible development is past. So you can go ahead. Now, it doesn't mean drink a half a bottle of scotch, but, you know, a glass of wine to calm me down, that's perfectly fine. It's probably better, it opens up your vasculature, you know. Lungs go through specific periods of development. There's what starts out as a pseudoglandular period. And it's called that because it looks like the branching pattern looks like a gland developing. It has the same kind of patterning. This is between 5 and 16 weeks. Branching is continuing. It's going from primary bronchi to secondary to tertiary, all the way down. It hasn't generated what's termed respiratory bronchi yet, but it's coming down to these terminal bronchi, where you're starting to get to a point where the next division is going to generate bronchi that can actually have respiratory units associated with it. So this is a pseudoglandular period. From 16 to 26 weeks, which is quite a long time, you have a canalicular period. And this is where bronchi are starting to divide into what's termed respiratory bronchi that can have alveoli attached, but it's really generating just more and more branching as fast as possible in order to get to a critical mass of alveoli for survival. Remember that 26 weeks here is past the date where you can determine viability of a fetus. If the fetus was born at 22, 23 weeks, that's before the end of this canalicular period, so you really do not have a lot of respiratory bronchi there. And that's not only maybe a surfactant problem, but just a general anatomical problem that child doesn't have enough surface area to breathe. One of the first things people want to do is put them on oxygen, just raise the oxygen content. Well, then you start creating free radicals that can damage a lot of tissue at that time too, so you have to be very careful how you treat these children. After the canalicular period, you have a terminal sac period. Terminal sacs are what are developing at the end of each bronchial unit, that then the alveoli will start to form off of those units. So you start to get the formation of all these primitive alveoli. This is 26 weeks to birth. Alveolar period is 8 months to postnatal up to a few years. This is where most of the mature alveoli form in the individual. So fetal stages in utero at birth, all of this is postnatal. All of this development is postnatal. So most alveoli form after birth. The canalicular period between 16 to 26 weeks, you're getting a lot of branch patterns. The airways haven't really associated with the parenchyma of the lungs, with the vasculature of the lungs yet. By the time you get to the terminal sac period, you're starting to get the formation of type 1 and type 2 alveoli, or type 2 cells that type 2s are going to start to produce surfactant, but they also start to associate with the endothelial cells of the vasculature as well. So you're starting to set up the framework of lung function. The lungs at this time are not inflated, they're non-functional, they're just developing in the blind, really. Approximately 90% of alveoli are postnatal. Eventually you'll get about 70 square meters of surface area in the lungs, and that's sufficient for life. Even if you take out one lung, you can still survive quite readily with half of that. But by this period at a newborn, you have functional alveoli with associated vasculature. Now oxygen can diffuse across these few membranes to get into the fetal blood and oxygenate that blood. You also have other cells within this alveoli. Some are producing surfactant, some are just structural components within that lung tissue. Surfactant is a mixture of phospholipids and proteins. It's produced by type 2 alveolar cells. So type 2 cell here producing the surfactant. It layers the inside of the inside of the alveoli with the surfactant. So when the child takes its first breath, the surface tension, the water surface tension, is reduced enough that will pop open like a balloon. If the surfactant's right there, you could force high pressure air into that child's lungs, you could not get those alveoli to open. So the surfactant is absolutely necessary to open this up. If a child is born at before viability or early stages of viability, 22, 24 weeks, child is born at that time, they may not have sufficient surfactant. You can apply Glucocorticoids, dexamethasone catecholamines, that'll increase surfactant release. You can also apply artificial surfactants. They used to supply cow surfactants to the lung. Anything to get those alveoli to open up increases the likelihood of survival. Premature birth, lack of surfactant can lead to what's called hyaline membrane disease or respiratory distress syndrome. This is all cellular debris that's surrounding this alveoli because the child is working so hard to get those lungs to function, they're starting to damage that lung tissue. And this could build up and occlude and inhibit proper respiratory function of that lung. Lung development, since you have trachea developing from gut tube, you have these tubes that are developing. You can get all these different anomalies in the formation of the tubes. If it doesn't separate sufficiently or properly, you can have trachea that maintains what's termed a fistula, a connection between trachea and esophagus. Here, esophagus didn't form properly and became atretic, so it's kind of a blind-ended pouch with the rest of the esophagus and the stomach continuing on down. What happens when this child tries to eat? He aspirates into the trachea, into the lungs, and starts coughing, can't breathe, not getting any nutrition down to the rest of the stomach, probably some projectile vomiting going on. Anything that goes in is going to come right back out. Same thing here. Anything that goes into this child is going to come right back out. So this needs to be addressed quite quickly because first of all, you need to get proper nutrition in, and also their airway is compromised somewhat. So these two are a pretty critical situation. This one is not as critical, although you have this fistula, but you can just go in and tie off that fistula really quick and solve the problem. And then you have two separate airways. This one's very similar to what you have up here, except you can get material to go in and come right back out through that esophagus, but it's still a very compromised situation. So you need to address these quite quickly and quite early.
For the top right one, is there risk of like stomach acid coming back up into the lungs?
Oh, absolutely, absolutely. The children, their superior esophageal sphincter isn't really formed that well, so they can get stomach acid, comes right in, aspirate into the trachea, and damage a lot of tissue in the trachea. But usually you see these, you can see these with ultrasonography, so you can be prepared for these as the child is born, and you go in and intervene quite quickly. Okay, so it's just a quick overview of lung development. Heart is a little more complex. Like I said, heart has to develop while it's functioning. So it starts out as a single tube and eventually ends up as this four-chambered structure. Humans have four chambers. Some animals have three chambers. Some have two chambers. Some have one chamber. We have four because we have two sides of the heart. We have a right side and a left side. Right side pushes blood to the lungs. Left side pushes blood out systemically to the rest of the body. So we have these four chambers. We have a right atrium. Blood enters the right atrium through the superior and the inferior vena cava. You see a hole for it right here. Enters the right atrium, pushes through to the right ventricle. Right ventricle contracts in systole and pushes blood out to the lungs. Blood goes into the lungs, is oxygenated, comes back through the pulmonary veins back to the left atrium. Left atrium pushes blood into the left ventricle. Left ventricle has very powerful walls. It can increase the pressure greatly, push blood out through the aorta, out into systemic circulation. So the left side of the heart has a much higher pressure than the right side of the heart in a normal situation. And that's important at the time of birth. When the child takes a breath, the lungs expand, a lot more blood is now going to the lungs, it's coming back in the left atrium, and that blood has high pressure in that left atrium. And that's important because during fetal stages, you have to have a way to move blood from the right side to the left side without going to the lungs because the lungs aren't inflated. They can't handle that volume. So you have to shunt blood from right to left. When the child's born, the lungs expand, those shunts are no longer needed, and that high pressure helps close off some of those shunts. We'll go through those in a few minutes. So right atrium, right ventricle, left atrium, left ventricle. This is a tricuspid valve. This is called an atrioventricular valve. It's a valve between the atria and the ventricles. This is a tricuspid. It has three cusps, three leaflets. This is a bicuspid or mitral valve. It has two leaflets. All of these little stringy things in here are chordotendineae attached to cardiac musculature. Those are to hold these valve leaflets stiff during systole. As this left ventricle contracts, it builds up a lot of pressure, and those valve leaflets want to blow back into the atrium. That's called regurgitation. So blood will move from the atrium into the ventricle, but if these chordotendineae are compromised, as soon as that contracts, it'll back blood back into the left atrium. So the efficiency of pumping is now greatly reduced. That can cause a lot of issues. So these chordotendineae are very important. There's specific viruses and infections that can affect those chordotendineae and damage them, and you start to get valve problems. The human heart also has surface arteries, these coronary arteries and veins. These surface arteries are derived from the serous membrane that's overlying the heart itself. Some species do not have coronary arteries. They don't need it. They just extract oxygen from the blood that's moving through the heart chambers. Humans and most large species have to have coronary vessels because the chambers are so big and so dense that they can't diffuse oxygen through the entire chamber. So they develop as coronary arteries. So there's a right coronary artery here, a left coronary artery. There's a venous structure that's associated with each one of those arteries. All these veins coalesce on the posterior of the heart in the coronary sinus, and that coronary sinus dumps that deoxygenated blood back into the right atrium. So the right atrium is getting blood from superior vena cava, inferior vena cava, and that coronary sinus. Heart is derived, if we're looking at an embryo that has not gone through folding yet, but it's gone through gastrulation. This is neural tube, the neural plate that's forming here. We're looking down from above, looking down onto the embryo. This region, this little horseshoe region here, that goes around the anterior portion of the developing neural plate, this is called the cardiogenic area, cardiogenic region. And a bunch of endothelial cells in here start proliferating very rapidly, and they start to coalesce. And as the embryo goes through folding, this region here gets pushed caudally and ventrally to come down to cervical level. So it's moving like this down to cervical levels. And as it's doing that, these endothelial cells are coalescing into what's termed a primitive heart tube. And this primitive heart tube is just a single tube. This primitive heart tube is what's going to go on to develop into the four-chambered heart, plus all the outflow tract structure and all the inflow tract structure of the heart. This head folding that drives this folding of the structure is driven by the overgrowth of the CNS anteriorly. All this is proliferating very quickly, so it pushes all that material caudally and ventrally this way. So it coalesces a single heart tube here, lying within this embryonic coelom. It hasn't subdivided into pleural cavity or pericardiac cavity yet, but it's a heart tube. It has endothelium on the inside, has some mesoderm surrounding it here, and has what's termed an epicardium or a visceral pericardium, the serous layer that's surrounding the whole structure. So the heart has three layers at this point. The heart, after it forms this tube, so this is at 22 days, there's already cardiomyocytes in there that are contracting spontaneously. So it's trying to move, it's trying to contract a large enough mass of this primitive heart tube to drive the blood in one direction or the other. It really doesn't know which direction to go, but it seems to drive the blood forward in the proper direction. After the heart tube forms, other cells start joining the region. Neural crest cells move in. This is what's called a secondary and a tertiary heart fields. These neural crest cells will move in, and neural crest cells will move in and form most of the right ventricle and also form most of the outflow tract of the heart. At the same time, this posterior heart field, this is more neural crest cells that move in. This pre-epicardial organ, this is a little outcropping growing off the same tissue that's making diaphragm. And these cells start to proliferate and then start to crawl over the surface of the heart. And this is going to produce the visceral pericardium, the serous layer overlying the heart. And also from this organ, all the coronary arteries are going to develop from that organ as well. So some species don't develop that because they don't need a pericardium, they don't need a coronary arteries, but humans and higher mammals do. So we have a primitive heart tube here, surrounded with endothelia, surrounded in myocardium here, between at this early stage where it's sitting at 22 days. Between the myocardium and the endocardium is a structure called cardiac jelly. It's really, it's just an extracellular matrix. People have used it. This cardiac jelly is like, there's a Wharton's jelly, this umbilical jelly too. People have used it to try to generate stem cell populations from other structures. They've had some success. So there's molecules and cytokines and factors that are laid down in this cardiac jelly to drive the proliferation of myocardium and to drive proliferation of the endocardium and the formation of the heart. So this myocardium begins to proliferate very rapidly. It starts to move into this cardiac jelly, and eventually the space that was occupied by the cardiac jelly is now occupied by myocardium. But it's still a single tube with an outflow tract. Blood is going this way. It's going from inferior to superior in the slide. So this is the outflow tract. This is where the aortic arches come into play. Those pharyngeal arches come into play. Each one has an aortic arch associated with it. This is the first aortic arch. This is the inflow tract of the heart. This is bringing blood from the yolk sac, from the umbilicus, from the placenta, starting to bring it back toward the heart. This heart is a primitive tube at this point. This dotted line is the pericardium, the chamber that it's lying in. This tube goes through a process called looping, heart looping. The more caudal regions of that tube will move posteriorly and superiorly. This is going to become atrial structure. In the middle here, this will remain as ventricle structure. And then the more superior parts will be part of the outflow tract, form part of the aorta, the pulmonary trunk. So this looping is bringing this atrial structure up posteriorly and behind. So by the time looping is done, the heart tube has gone through this little loop here. By the time it's done, you see what was sitting way down here is now superior and is forming the atrium. So the heart has gone through looping to generate almost what you see in a normal heart, except this is all still one big chamber.
Is that why we call the heart of the top the base? Because of the looping?
You call the top the base because the heart has an apex down here. So it comes to a point, so that's why you call that the apex. If that's the apex, the outflow tract up here, everything coming off the top would be the base. So now you have something similar to a normal heart. We have a right atrium, a left atrium. What's developing is a right ventricle and a left ventricle. But all of this is a common chamber. They haven't septated yet. They haven't divided into separate chambers. So looping has occurred. Here's a right atrium, left ventricle, left ventricle. That's a common ventricular space. That's a common atrial space. There is no separation between the two. This is a separation. This atrioventricular canal here is the connection between atrial structure and the ventricular structure. So all this atrial structure is lying posterior here, and it's connected to the ventricles through that little canal. This canal starts going through some specializations. It starts to develop these what's termed endocardial cushions. And these cushions will grow out and fuse with each other eventually. And it will separate that atrioventricular canal into a right and left canal. And this is going to form the basis of the right and left atrioventricular valves. Eventually, this ventricle will septate out, and the atria will septate out and create four chambers, but this is the first step in that septation. So we're looking at a frontal view. This heart has been cut frontally, like this as it's developing. This is a sagittal cut. So you can see those atria sitting here. This is the atrioventricular canal that you're seeing here. This is a common ventricle, and this is the outflow tract coming out. So that the endocardial cushions close down, now you have a right or a left and a right ventricle on either side of those fused cushions. This is back to a frontal cut showing right atrium, left atrium, common ventricle, right and left atrioventricular canals. So blood's moving into that right ventricle, just moving freely through this, the ventricle, right atrium, the ventricle contracts, it sends blood out through this outflow tract here, but it's very inefficient because every time that thing contracts, blood wants to move back into the atria, blood wants to move everywhere. But in general, it's moving forward. But it's very inefficient. So you have to start increasing the efficiency because this embryo is getting bigger faster. So you have to start increasing the efficiency of that blood flow. And the way that was devised to do that was to start separating these chambers from each other. And so you can increase and be very precise in where blood is moving at each contraction. So right atrium, left atrium, right ventricle, left ventricle, still all a common chamber, but you start to get these septum to start to form. The first septum that starts to form is the septum primum, first septum. It starts to form from a more superior portion of the atria, and it starts to move toward those fused endocardial cushions. So it's trying to separate the atria into a right and a left atrium. This is the inflow tract. This is where superior vena cava and inferior vena cava are coming in. So here we're looking at a frontal section. Over this side we're looking at looking from lateral at a sagittal section. So here's that septum primum begin to form, coming down from the top of the atria. It'll start to approach these endocardial cushions, and eventually it will seal off, form and completely close off from those endocardial cushions. So this is septum primum. This region that's closing off is called foramen primum, the first foramen. That will close off. As it closes off, apoptosis, cell death, starts in a more superior portion of that septum and starts to open up another foramen called the foramen secundum. This is important because you still, even though you're closing off these two chambers, you still need the blood to pass from here over to the left atrium to move out to the body, because this blood's already oxygenated by the placenta. It doesn't even need to go to the lungs. But also the lungs can't handle a large volume of blood, so you need to bypass the lungs by shunting blood from right to left. And this is one of the shunts, this foramen secundum. As this second foramen, as this foramen's closing off, this foramen primum is closing off, a second septum begins to develop. This is septum secundum. As this septum's developed, it begins to overgrow. You move forward. It begins to overgrow that foramen that developed by apoptosis. And now what you've developed is what's called a foramen ovale. Blood comes in from the right, pushes through that little leaflet, and goes to the left, and that's a one-way valve. It can't go back. So now blood is actively directed to the left-hand side. It cannot return to the right. So now you're much more efficient, more precise. You can take oxygenated blood here, send it over here, send it out to the body without ever going to the lungs at all. Some blood has to still keep going to the right ventricle and it gets pumped to the lungs because the lungs require some blood for proper development. So some blood still has to go through, but it's something like 15% of the volume that's going to the lungs, whereas the rest of it's being shunted across. So now the two atria are completely separated from each other. There's a right and left atrium. Blood comes in, oxygenated blood coming from the placenta comes into the right atrium, bypasses the right ventricle by pushing through here to the left atrium, and then moves to the left ventricle and is pumped out to the body. So the efficiency has increased quite a bit. This foramen ovale will stay open throughout fetal stages. After birth, the lungs expand, much more blood can go to the lungs, much more blood fills back into this left atrium. It's also oxygenated blood, so it has a much higher pressure than the deoxygenated blood that's now over here. So it pushes this little flap closed and holds it closed. Eventually that little flap fuses, and now you went from a foramen ovale to a fossa ovale. There's no more, blood does no longer passes through. In about 30% of the population, you can take a probe and push that back over and it never actually fuses properly. But there's asymptomatic. As long as it stays like it's fused, there's no problem. But you hear about people with a hole in the heart. This would be an atrial septal defect. There's a defect or a hole in this septum somehow. It decreases the efficiency. Now you have oxygenated, deoxygenated blood mixing. So now we've separated the atria that are right and left with this shunt that allows blood to shunt from right to left. So the atria are now septated, but now we still have a common ventricular chamber. So a little bit later, 44, 46 days, you start to get this growth of this very, what's termed a muscular septum. This growth starts to growing up toward the endocardial cushions, but never actually reaches them. It kind of stops. But this is all cardiomyocytes. This is a very muscular, a contractile tissue. As that atrial septation occurred, it continues on down to the endocardial cushions and actually seals off the rest of this ventricle here as a membranous ventricle. So you can see this muscular septum has grown up, but it doesn't actually reach the endocardial cushions. Then a membranous structure grows down from the endocardial cushions and connects to that muscular septum and separates the ventricle chamber now into a right and a left. So at this point, we have a right and left atrium and a right and left ventricle. So we have 4 chambers, but we have to develop this valvular structure in between the atria and the ventricles in order for those chambers to be functional independently. Right now, during systole, if I contract those ventricles, I can just push blood back into the atrium. But with contraction, I'm also pushing blood out to the body or out to the lungs. So the efficiency has increased, but it's still insufficient to support it's insufficient to support a newborn. So you need to go through the development of these valves. And the endocardial cushions and the side walls at this atrioventricular location start to go through this formation of the different valve leaflets. And a lot of this is dependent on blood flow. Blood flow is like a sculptor at this point. It helps to sculpt out these structures, but also you have to get the formation of these chorda tendini and these structures called papillary muscles